Okay, we're going to get started. So thank you again for joining today's webinar with Dr. Tom Nutter and Dr. Tom Allen in regards to the Cook County Health's Office of Behavioral Health, where we've been going and where we're going together. Again, my name is Deborah Hodges. I'm the Association Manager with IOMC, and I've been with this wonderful group since 2019, and I'm glad to be here with you today. So we're going to go over just a few points before we get to the actual presentation. And I know that's your whole purpose of being here. So we're going to be brief in regards to this. So we're going to cover just an upcoming program so that you don't miss it. That's on our calendar. We'll immediately go into our presentation. Then we'll have a question and answer session. We ask that you use the chat box or the Q&A box in order to post your questions. And then we'll be closing. The webinar is planned for 1 hour. It may run a little bit over. We'll just see how everything goes with all of your questions and your answers. So if you're unfamiliar with the Institute of Medicine of Chicago, I'd like to just let you know a little bit about us. It was founded in 1915. It's an independent nonprofit organization of distinguished leaders in the health field. They collaborate to improve the health of the public. The organization is celebrating its 110th anniversary this year. It draws upon the experience of diverse membership and other regional leaders, and overall it addresses critical health issues and a range of interdisciplinary approaches, including education, research, and communication with strategic partners and trusted information. It's a 501c nonprofit organization. As I mentioned, I wanted to bring to your attention 2 great initiatives that are taking place at this point in time. The 2025 Leadership Awards the competition is open. It's open to everyone. You do not need to be a fellow or a member of IOMC in order to submit a nomination. There's no fee to enter, so there's no barriers here in order to recognize yourself or some other great colleague or your organization. There's 7 particular categories in order, plenty of opportunity for people to be recognized. The deadline, though, for that competition is April 23rd, so please make a note of it on your calendar. What's also coming up is on June 26th, it will be the 110th anniversary of the Institute of Medicine of Chicago. It is the 2025 Leadership Awards and annual meeting. That is a fantastic meeting to attend for networking. It generally has about 125 to 150 attendees. The speaker for that event is under development right at this time. And again, it's open to all. You do not need to be a member or fellow of IOMC. If you're interested in an exhibitor space or sponsorship, please contact the office. We'll be more than happy to help you in regards to that. If you are not a fellow and you would like to nominate yourself or obtain a referral for a nomination, we highly encourage it. Just go to the website, iomc.org, go to the membership area. It's a wonderful group of individuals, thought leaders. They're committed to social change for the betterment of public health. There's a lot of tangible benefits. There's education forums, work groups, and partnerships for you to be able to join. And it's open, membership is open to everyone. At this point in time, too, I'd like to point out something that's recent in the last 6 months is the Career Job Center with the Institute of Medicine of Chicago. You can post a job on it if you are an employer or a recruiter, or you may, if you want to look for your next appointment or journey on your career, developing your career, you can also post your resume on that. And there's a lot of wonderful opportunities on that Career Job Center. So we hope you check it out. Today's learning objectives for this particular program, we hope that you'll walk away and appreciate the scope of the behavioral health crisis nationally and locally. Also, to be able to share the findings of the 2024 Cook County Behavioral Health Summit, and also the needs assessment and the workforce assessment. We have posted in the chat box a copy of the strategic plan, so your feedback is welcome to Dr. Nutter in regards to this after the webinar itself. And also you can connect through us if you desire to do so, and we'll be more than happy to share those comments with Dr. Nutter in his office. The third objective is to be able to describe the steps that the Cook County Health's Office of Behavioral Health has taken, and they're convening and coordinating with their partner organizations to enhance the collective advocacy of this great avenue. Today's speakers, as I mentioned, is Dr. Nutter and Dr. Allen. The call to action for this particular webinar is to better understand the current behavioral crisis, both nationally and locally, and learn about the upcoming opportunities to take part in the efforts to improve the behavioral health landscape for all Cook County residents. So at this point, what I'm going to do is introduce Dr. Allen, who is the moderator for the program. Dr. Allen is a fellow of IOMC. He serves as a director on the Board of Governors here with the Institute of Medicine of Chicago. He's currently leading the behavioral health work group. And he'll tell you a little bit more about that and what the activities of him as the chair and the work group are doing. He also serves on the program committee and the membership committee. In addition to his volunteer work with IOMC, he's the executive medical director of behavioral health at the Healthcare Service Corporation. He acts as the chief psychiatrist for Blue Cross Blue Shield Medicaid program here in Illinois. So in regards to that, Dr. Allen, I am going to turn this program over to you because that is the reason why everyone is here.
Thank you, Deborah, and welcome everybody. It's so nice to have you attend today's presentation, and I'm excited to introduce Dr. Nutter and hear Dr. Nutter's presentation. But before we start, I just want to give one plug for the IOMC Behavioral Health Work Group that Deborah mentioned. It's recently started. We have a few fellows who are members, and we've defined our purpose, which is to address the urgent behavioral health needs and improve equitable access to care for people of Illinois. So after that, we'll develop our objectives and then our action plan. So anybody interested in participating in the work group, feel free to reach out and we'd love to have you participate. And now I'd like to introduce Dr. Tom Nutter, who is the Chief Behavioral Health Officer at Cook County Health. In this role, Dr. Nutter provides leadership and clinical expertise in expanding Cook County Health's behavioral health programs and supporting community-based services. He's responsible for growing access to care for patients with mental health conditions and substance use disorders, as well as for justice-involved patients. Dr. Nutter is a board-certified psychiatrist with broad clinical interests and more than 20 years post-residency clinical experience that includes private sector, public sector, and academic settings. Prior to joining Cook County Health, Dr. Nutter served as Chief of Mental Health at the Edward Hines Jr. Veteran Affairs Hospital, one of the VA's highest performing 1A systems of mental health care. Dr. Nutter is a graduate of Valparaiso University and the University of Illinois College of Medicine in Rockford, and he completed his psychiatric residency at McGaw Medical Center of Northwestern University. So without further ado, I'd like to introduce Dr. Nutter, and thank you very much.
Thank you, Dr. Allen, and thank you, IOMC. It's such an honor to be able to present to this group, especially hearing a little bit more from Deborah on the history of the IOMC. As a new fellow myself, attending my first meeting and being the speaker at my first meeting, I am hoping this isn't also some sort of elaborate hazing ritual. I do also notice we're a fairly small group, so we can keep this relatively informal. I know Tom's going to be keeping an eye on the chat, so if there are things that come up, though, I think we can be relatively informal as we go forward. So this is a time of mental health crisis, as we've heard a lot about. These are just a few statistics from the most recent SAMHSA survey. Between 1 in 4 and 1 in 5 adults 18 or older had a mental illness in the last year. SAMHSA, by definition in the survey, does not include substance use disorders in the mental illness category. So an additional 17.1% of those 12 and older had a substance use disorder. Nearly 50% of young adults, and this, believe it or not, is actually down from the previous year, aged 18 to 25, endorsed having a significant episode of mental illness, SUD, or both. About 1 in 8 adolescents experienced not just suicidal ideation, but serious thoughts of suicide over the previous year. So thinking about that in terms of just again, typical high school class size of 25 or 30, that's 3 or 4 kids in every class all day long. Nearly 50% of adults reporting mental illness did not receive treatment. And even more concerningly, almost 30% of those with serious mental illness received no treatment at all in the previous year. About 40% of adolescents with a major depressive episode did not receive treatment. And there are multiple reasons for this last statistic, but 23.6% of those 12 or older needing SUD treatment receive treatment. Again, some of that is help-seeking behavior, but there are also significant access issues. Next slide. As we're all painfully aware, overdose deaths are substantially higher than in the past. When I graduated from residency, I think Dr. Allen graduated a few years after me from Northwestern, but when I graduated, at the bottom of that, on the far left side of that, of these bar graphs, you can see that the incidence of overdose deaths was um, about six-fold lower than in the more recent statistic here. It's gone from under 20,000 a year to well over 100,000 a year. And in Cook County, in 2022, over 2,000 residents died by opioid overdoses. Now, I think some of us have heard the early reports that the numbers for 2024, which aren't finalized yet, are lower, fortunately, but we still have quite a ways to go, and we can certainly talk about that a bit. This does not look terribly impressive, but it is in fact about a 30% increase in overall suicide rates over the course of the last, and virtually every time I've seen supply and demand curves over the last decade, particularly in outpatient, the story is roughly the same. I included a couple of slides here. These are from HRSA from about a month or so ago. So these are hot off the presses. And this is the most optimistic of these, showing a pretty sizable national increase in supply of social workers. That's the blue line there. But even that fairly sharp increase doesn't keep up with demand. Next slide. Less encouraging story for psychiatrists. Psychiatry is a relatively old profession in terms of the mean age of folks who are practicing psychiatrists, and so nationally, supply is remaining flat, and demand shows no sign of decreasing at all. The HRSA has probably a dozen or so of these curves for various disciplines, and the majority look somewhat more like this than like the social work curve. But the bottom line is the same, that we have a crisis. We don't have enough folks receiving care, and the gap between the amount of care needed and the number of folks to provide that care is growing wider year by year, even now, and projected into the future. This is also in many ways a time of unprecedented opportunity, given the prevalence of mental illness, and even though that prevalence is growing, awareness has really never been greater across the country and even across political lines. I'm from a small town, and a town that voted differently than I did in the last election. And I would say awareness of psychiatric conditions is probably it's substantially, even there. I feel like there's growing appreciation, because mental illness and substance, and by the way, when I talk about mental illness and substance use disorders, I include substance use disorders in mental illness, and I use the terms behavioral health and mental health. I know a lot of folks make distinctions. I'm going to use them synonymously, mostly for simplicity's sake. But that almost no one is untouched, and so as a result, there's been, I think, fairly strong political will to improve behavioral health care in a way that has not really existed previously in my career. Given the impossibly high demand, organizations providing mental health care have much less reason to compete than ever was the case before. It's been very striking in the work that we've done in the community over the last year and a half or so, that there is, certainly there can be competition for scant resources, but in general, there's much more cooperation and collaboration than there is competition. Because of the Affordable Care Act and the rises in value-based care and expansion of telemedicine, salaries, at least in some mental health professions, psychiatry specifically, psychology to some degree, have gone up, although that hasn't been the case for all behavioral health professions. And then research dollars have also increased over the last decade fairly substantially. Now I'm pausing here because yes, this slide was crafted prior to January 20th, and it's been quite a week. It's been an uneasy time for those working in public health spaces and in healthcare, and in a lot of ways, a particularly difficult time for those that we all serve. That having been said, I still do believe that our best days are in front of us in terms of, as a field. I do believe that there is widespread support for stronger mental health systems of care. But given events of the past week, um, I realize that may even seem a little uh, off key in a way to emphasize. And of course, none of us do have a crystal ball. So if indeed I'm not correct, and this is in some ways a high watermark, I feel very grateful personally for being able to, in such a time as this, to be in the role that I've been able to for the last year and a half. So what is this Office of Behavioral Health? We are a new office. Really, there was a previous version of us, which consisted of essentially one person and an admin between the establishment of ARPA. I think ARPA was signed in 2021. With funding rolling out in 2022 and plans made at the county level in around 2022. Our entire team, with the exception of the one admin person that I just mentioned, have been here for a year and a half or less. We have one staff member who started in July. I started in August of 2023. But we've been given what I would say is a once in a generation opportunity and $74 million of ARPA funding to try to bolster the entire behavioral health ecosystem countywide and also within CCH. So that's, as is mentioned here, that it's a twofold mission. The within Cook County Health has been a much more kind of behind the curtain kind of role. None of our clinical staff report up through our office, but we've been able to bring a lot of folks together. We're crafting some internal strategic plans, things that we'll not really be discussing today, but our bigger role in the first year in particular has been countywide and in front of the curtain, try to be a coordinator and a convener of agencies countywide to try to really, again, impact the entire landscape of behavioral health throughout the county. Next slide, please. So this is a pause because, as I mentioned, funding started rolling in 2022. Consultants had been hired, and various projects had been initiated in 2022. But our entire office really doesn't exist until 2023, and even now we're still forming the rest of our team. In 2022, the Office of Behavioral Health was largely a one-woman show. Pam Esposito, who was Senior Behavioral Health Officer during that time, juggled all 20 or so of these projects, and everything that I'm going to talk about that we've been able to do since then has been largely because she carried the ball and juggled a lot of mixing my metaphors here. Juggled a lot of balls, spun a lot of plates, whatever the metaphor you want to use, for really well over a year before we got the momentum that we did. She is now happily retired. I think this is a great retirement photo with the tan lines, the whole thing. It's very Florida. So we wish her well and appreciate her. So this is a to-do list from the time that our office was initially forming. Of course, for any endeavor, step one is get the right people on the bus. The second thing is get the right people on the bus. And the third thing is get the right people on the bus. So job one has been to hire an outstanding team. We're still wrapping that up, but I'm happy with the folks that we have working with us at this point. And then there was actually 3 separate kind of evaluative assessment projects occurring that had already been planned. but hadn't been initiated yet upon our starting. One was the summit that probably several folks on this call attended last February. The second was a countywide community needs assessment that was completed in late summer, early fall. And then a workforce assessment that was funded through ARPA funding and CCDPH, and we collaborated with CCDPH, the Cook County Department of Public Health, on that workforce assessment. And that presentation was in symposium was in October 1st, I believe. So it's worth pointing out that typically what you do in a situation like this is that you do the assessment and the analysis and then make your plans. We did not have that luxury, given that all ARPA dollars needed to be obligated by the end of FY26. So we could take the early insights gained from those processes and put them into grant making. And really all of our, we'll talk some more about that in a couple slides. And then really all of our external efforts have been coalescing into a countywide behavioral health strategic plan that we're hoping to unveil within the next few weeks. And the final version of the next few weeks, the current draft has been in your, has been sent to everybody here. So we did have an open period of for open comment, which ended last Friday, but there's still time. So as was mentioned earlier, email IOMC, email me with any thoughts you have if you get a chance to look at that in the next few days. And then these last three things I'm not going to spend much time on today, but we also had, as I mentioned earlier, a number of other projects that had been initiated and needed to be followed through. And that included opening a clinical triage and stabilization center at Provident, which we'll talk about later on in this presentation. And then something I won't mention further is assessing strengths and weaknesses within our system and CCA and developing plans for improvement. Next slide. This is our team, and I am, as I said, I'm thrilled with the folks we have, and I'm particularly happy to have a leadership team that is not only a group of accomplished people who are fantastic to work with, great collaborators, thoughtful, energetic, but a group that have a real diversity of experience. So as was mentioned, I'm a psychiatrist. I've worked in various settings, and including most of the last, for the 14 and a half years before I was here in the VA system. Dr. Gomez is a psychologist who has a lot of experience in the carceral settings, but has also worked in community mental health centers and has been very involved in Native American populations and systems of care. Jennifer Brothers, who is a public health dynamo and does amazing work, someone with an MPH. Greg Lee is a social worker by training, but also had been in an executive level position at a local community mental health center, community agency, and has importantly 7 or 8 years, I believe, of MCO experience. So bringing a group like that together that has such a diversity of experience has been just an incredible experience. Really, our entire team has doing, I think, amazing work. So as you can also see, we've got a few vacant slots and hoping to be complete as a team in the next few weeks. Next slide. Okay, so this was the next slide was you could skip the summit slide. That's so as folks remember, there we go. The summit was last February, and really gave our office an appreciation for the appetite that the community has for someone to step in and take a convening, coordinating role across the county. We had very little time to plan the summit, and an email list that was much less developed than it is today. And essentially within, I think, less than 2 weeks after opening, posting information about the event, we had to close registration because 700 people had signed up, and we had to then sort of trickle in to make sure that commissioners, and commissioners can get invited, and and members of the board of directors could be invited, those sorts of things. So we had about 300 organizations represented that day, and it was structured as a set up as a day of structured listening. And so we got a lot of, I think, meaningful feedback from that, which will be on the next slide. This is a kind of high-level summary of the findings. I don't think it'll surprise many folk, but big point of emphasis for the day is that there just aren't enough people in the workforce, and that certain areas are even more certain geographies have even bigger challenges in maintaining a workforce than others. Access is a huge issue in a related story, particularly in communities of high social vulnerability. There are issues, a lot of issues were mentioned about coordination of care, alignment of care, inequities, stigma. I think I was a little surprised at the amount of the number of folks who mentioned stigma. I think stigma may not be the global problem that it was 10 or 20 years ago, but we have pockets of stigma, I think, that are probably just as strong as ever, and that need to be addressed. There was a strong push not to act in a top-down manner, to really emphasize prevention and early intervention. And there was a lot of discussion about health-related social needs, but housing issues came up particularly frequently. We did not have sufficient data to really find regional differences in this particular meeting, and the final report, the kind of summary of that final report is included in a link here. I should say the other thing that the summit did, besides give us information and a sense of the pulse of the community, was to really build momentum for coordinated efforts in the behavioral health space. Next slide, please. This is a community needs assessment. I'm going to talk comparatively less about this for simplicity's sake. But I do think, and particularly for those working in community agencies, in which once grants are back, once public grants are federal grants are happening again, and for other grant making efforts, I think the data in the community needs assessment will be a valuable. I think this is going to be a valuable resource for folks. So essentially what our consultant did was to look at the various community needs assessments from, I think it was 14 local hospitals. They did some focus groups, a bunch of informant interviews. They had a survey of over 200 people, and then wrote up a list of recommendations. Next slide, please. And I'm not going to go into the details about these recommendations, although they are detailed in the link here. I just listed here on the slide this strengths. I think we sometimes forget just how well represented we are. We have a lot of great agencies in Cook County. We have a real strength in terms of our academic institutions in Chicago. We have a history of progressive politics in Chicago, and a real emphasis on equity and social justice. And in terms of gaps and opportunities, again, no surprises there. Housing instability, public safety, stigma, economic security, challenges related to access. Again, while I'm not going to go into a lot of detail about this because it's got some redundancy with the other assessments, I do think it's going to be a valuable tool in terms of as a reference for grant making, for not just for Cook County Health, but for all agencies within the county. Next slide, please. Okay, that brings us to the third and final of the assessments that occurred this year. And again, the full report is here. Next slide. And these are slides that were put together by our colleagues at Sage and Trailhead, who are the consultants who worked on this project alongside us. And thank you to those who served including Dr. Allen, on the steering committee for this effort. So bottom line is the there was an estimate of the current number of behavioral health professionals in our workforce today as of 2024, and that number is almost 31,000. With but to meet the current demand based on estimates of need, another approximately 16,000 folks would be needed. However, given the number of upcoming retirements and trends of folks leaving the field, the actual estimate of the number of new hires needed to meet demand by 2028 is to almost double the current workforce. If we're 30,800 now, we would need an additional 29,700. There's the big headline, but just by the year 2028. So the shortage is big. Next slide, please. Sorry, I didn't think about the fact that I wasn't going to be driving when with the animations there. Sorry, Deborah. And the shortage is not evenly distributed. As we all know, there are plenty of not it's really a shortage everywhere, but in downtown, it's much easier if you're in the loop to find a psychiatrist. The further south you go, the further west you go, the fewer and fewer providers you find. The majority of behavioral health workers were female, except for psychiatrists. And this can be particularly an issue, as was discussed a bit at the symposium, among those working with young men and looking for therapists for young men. Black workers were underrepresented in higher paying professions and overrepresented in lower paying populations, but Hispanic and Latinx folks were underrepresented across all professions within mental health. Next slide. As part of the workforce assessment, there was a survey of nearly 1,000 folks working in the behavioral health field in Cook County. And though you can see a lot of the most common areas of dissatisfaction are related to economics, the personal economics of the behavioral health worker. The number one area of dissatisfaction is the ability to get clients the help they need. So as we can make improvements to our system, I'm hopeful that can help us to retain more folks and need to recruit fewer than 30,000 in the next 3 years. So the plan generated the workforce assessment generated 5 separate recommendations, and you can just click through all of them here. These are the 5. The first is to work toward competitive compensation, particularly for folks on the lower end of the scale. There was a finding in the workforce assessment that of the folks at the lower end of the scale among mental health workers, so the category, I think they called them community health workers, which are like peer supports and similar roles to that. Approximately 75% were making at or less than a living wage, and that's living wage calculated for a household of 1. So presumably, since most of those folks were not in a household of 1, and since Chicago is one of the most expensive places, probably the most expensive place to live in the Midwest, we are not surprisingly having a difficult time holding on to those folks in the workforce. Second was to increase awareness of behavioral health careers. There were a number of comments from folks who said, "How do I aspire to a career that I don't know exists?" Probably the most high impact piece of the recommendation among the 5 is to set up a learn and earn fund to provide scholarships for social work internships, CADC apprenticeships, these sorts of things, investments that could be the difference in someone being able to choose a career in behavioral health and not being able to do so. And again, some of the amounts of funding for each individual learner would not necessarily need to be that high, and could also be, help us target populations that are currently underrepresented in the workforce. Fourth was to improve job quality, and to try to essentially band together to try to, among agencies, to try to um, um, provide education and information to those in the workforce. We want to make liberal use of the Illinois Behavioral Health Workforce Center, which has been doing outstanding work. And then lastly, to maximize the impact of the current workforce, there's an emphasis on reducing documentation burden, expanding integration in primary care, and exploring new technologies, including. Okay, so we had 74 million to spend, only a few months to spend it. What's the best way to make use of those funds? And we felt that the highest yield thing would be to initiate a competitive process, and one that targets areas of historic disinvestment. And I have to say the team that worked on this, Jennifer Brothers and her team, did absolutely amazing work. And as a result of, we were able to distribute 44 million in grants, and get all those contracts done before the obligation deadline. And I'll argue, in terms of stewardship of what we had as in ARPA funds, this was has been a success and will continue to be a success going forward. So next slide, please. As I said, we wanted to target areas of historic disinvestment. We did not want to necessarily have grants just go to whoever has the best grant writing apparatus in their organization. So we tried to use this as an opportunity to empower local agencies as well. As a result, we had 2 informational sessions, a lot of capacity building workshops. All the questions and answers were kept in an FAQ document that was posted online. We tried to streamline the application process to minimize the number of things that were needed for each application. Instead of just a kind of a checkbox system for do you work in a high SVI area, yes or no, we scored each application based on which communities they were serving and what percentage of effort was going to be focused on which area, and as listed with the social vulnerability index scores for those communities. Faith-based organizations, FQHCs, community health centers, educational agencies were eligible to apply. Essentially anyone other than for-profit organization. Next slide. And then each was independently reviewed, and the highest scoring organizations were presented for review by our office. And after some long sessions and difficult arguments, because I can say after having read all 324 applications, or at least skimmed them, there is a lot of amazing work happening in this county. Next slide. So this was the day in June in which the 44 million were awarded to I think it wound up being 53 different organizations across Cook County. And it's always a good day when you can give away $44 million to agencies that are going to make very, very good use of it. Next slide. This is where the funds went. About 60% went to efforts for youth and families. We have an eye toward prevention and early intervention. So you can see the prevention and early intervention and for youth and families, and the treatment, recovery, and support services for youth and families totals it'd be about 27 million of the 44. And typically these projects were, youth, were programs for youth, some in school, some out of school, a lot involving screenings and improving screenings. An additional 13 or so million went into programs for adults. And again, a lot of screenings, but also a lot of programs for various populations that are underrepresented, grants to Hispanic and Latinx organizations. There was one to a low vision organization. There were a couple for those with serious mental illness, substance use disorders. Um, and then, as we've probably all heard quite a bit about in the last few years, being in emergency rooms is not the emergency rooms are not the best place to be when you're having a psychiatric crisis, and police aren't necessarily the best people to manage those situations. And so there's been a lot of investment at the national level and the state level, and now locally too, in the crisis care continuum. So about 4 million went for a project in that space. Next slide. Organizations awarded were kind of a bimodal distribution between larger organizations and smaller organizations. We were pleased that 21 of the awardees were agencies of 100 or fewer employees. Next slide. And this is where the funds went. You'll notice that these numbers add up to more than 53 because a lot of projects serve more than one region. So I know this is a little bit of a busy slide, but for Chicago, we use the home equity zones, health equity zones used by the Chicago Department of Public Health. And for suburban Cook County, we use the regions used by CCDPH, with the exception that at Summit, the Northwest folks met separately insisted on being separate from the North folks. So this is the breakdown by region of where the funds went. You can see in Chicago, most of the investment went west, southwest, and south, and similar pattern in suburban Cook County. Next slide. You can also see that there was a high level of investment in the communities. These are the highest SBI communities, according to the latest census data in Cook County, and the number of projects in each from Stronger Together. Next slide. And then I did mention that we had a number of other projects that had been ongoing upon our team coming together. One of those, well, I'll list, I think I listed about a half a dozen or so here, of what are probably about 15. CCDPH already had an arrangement with Family Guidance for a mobile harm reduction unit, and that had been very successful. So we were able to expand that into Chicago. We were able to add, through Thresholds, a assertive community linkage team for folks in RED. We were able to add a living room to Southland. So someday soon, I think Ron's on this call. One of these in the next few weeks, hopefully, we'll finally be opening an OTP at Austin. We have some new psych beds, peds psych beds at Stroger, and we've been able to place a lot of naloxone vending machines, and are continuing to expand that work over the next few months. Next slide. Okay, and then I mentioned earlier the CTSC. This is we're going to wind up using it. It's sort of a CSU, clinical stabilization unit kind of a model, but for billing purposes, the most feasible way for us to run this was to have folks come in behavioral health crisis, fast track through the ED. Again, assuming that we're not certain they're going to need inpatient admission, and then it's a 23-hour OBS, be a 23-hour OBS unit, staffed by APRNs 24/7. They'll have a medical director, the RNs on every shift. There's a justice involved coordinator for those who are justice involved in the project. Again, really focused on rapid crisis resolution, safety planning, and the like. We are very excited. Literally, the folks who are going to be running that program are doing orientation a few doors down from me right now. So we're hoping this opens in the next few weeks. You'll likely see something from us on this soon. The idea is, as I mentioned, EDs are a terrible place to have a psychiatric crisis. And so the idea is to get folks into a much more peaceful, calm space and surrounded by a knowledgeable and compassionate group who can walk folks through their crisis and into as seamlessly as possible into outpatient care. Um, and there's a picture of the what the unit now looks like. Well, this is actually a conceptual drawing. Deborah, could you advance? Yeah. So the only difference in what this actually looks like and the drawing here is that the chairs are blue and not not that cream color. But again, we'll be opening hopefully in the next few weeks. Next slide. As I said, all of our efforts are really leading toward a countywide strategic plan. Would love to have folks review that plan if you can. We've set it up as a kind of a 5-prong effort. The first is systems alignment, and specifically that refers to setting up regional collaboratives so that we can get um, granular data and have our efforts be much more locally focused, not just now, but going forward. So that regional collaborative system is being set up, and we've had initial meetings there in December, and hopefully roll that out. We're going to be looking at aligning, assessing and aligning funds flow, and setting up dashboards that are countywide, again, as part of that systems alignment effort. The workforce development is essentially the plan that we just saw from the workforce assessment. Prevention and early intervention for youth and families. This involves reducing inequities, again, increasing screenings, um, creating local resource directories, collaborating with the state and their Beacon program, which has just been rolling out in the last few weeks. The access to treatment, recovery, and support. Um, again, addressing gaps in care, really expanding collaborative care, and reducing opioid deaths. And then lastly, trying to improve coordination of the crisis care system. Next slide. So again, these are the collaboratives. Um, it's that same using the same methodology for the health equity zones and the same zones essentially used by CCDPH for suburban Cook County. Again, we've had the opening set of meetings with the collaboratives, and we hope to be vetting our future efforts through the collaboratives and meeting with each of the collaboratives quarterly starting in March. Next slide. And then among other things that we're excited about is, we don't have the front door to our systems of care has been problematic. And since there were just simply are not enough providers, but to have um, an experienced navigator with an extensive database at that front door, I think is a huge thing. So we're going to be expanding use of NAMI's helpline as front door across the county. Their database includes over 1,000 organizations. There'll be text and chat functions as well. And will also importantly allow us to get some cross-agency data and wait times data that we really don't have access to at present as we monitor and plan future efforts. Next slide. So next steps, again, is going to largely be focused on implementation of the strategic plan, completion of the Stronger Together projects, and the several hundred metrics that are being tracked through those Stronger Together projects. And we particularly want to emphasize the development of the regional collaborative. So I think I have left at least enough time for questions. Sorry for rambling there just a little bit, and thank you for your attention.
Well, thank you, Dr. Nutter. This was a fascinating, really informative presentation. Very eye-opening in terms of some of the challenges we have across Cook County, across the state, across the nation, and really give a lot of credit to you and your team for digging deeply to find out what some of the challenges are and proposing solutions. So this is really excellent. Um, I guess I just have and anybody on the meeting today, feel free to put questions in the chat. But I'm just wondering, looking at your strategic plan, Dr. Nutter, there a lot of the solutions look on point. They look very relevant and necessary. I'm just wondering, is there a sort of a stratification, or is there a sort of an immediate short-term, long-term approach? Like, are there some strategies you want to do in the next year or two, and the other ones are later, or are they going to be all kind of attacked at the same time?
Well, the theme of our last year has been everything everywhere all at once. So we're kind of growing used to that, but it's that's obviously not a terribly sustainable strategy for the long term. Um, so I think for us, um, setting up the structure is really, really building the collaboratives, I think is going to be the probably the highest yield. Building a foundation for future efforts is probably the highest priority at present. Um, I want to, we want to expand the NAMI project to be able to get us and to get data. I think to really establish those structures and establish, what data we're going to track and and make sure we have the folks on board that we need to have. And I mentioned having the regional collaborative meetings quarterly. The other meetings that we're going to be continuing to have quarterly will be with our intergovernmental partners, since again, there's so much effort going on at so many levels. But I think it's basically um, building the collaboratives and following through on the things that we've started, both with the Stronger Together project and the dashboard stuff.
One of your strategies that really stood out for me is alignment, systems alignment, and particularly data. And I know there are a lot of data there that you're looking at, but I'm thinking specifically about clinical data. And this is sort of the $64,000 question. If you had a magic wand and you could find a solution to, say, health information exchange or something to remedy the fragmented behavioral health care that we see all over. It's not integrated with physical health. People are kind of reinventing the wheel in their own clinical settings. We don't really know what's going on because people going from one setting to another. But is health information exchange part of the strategy? And if so, how do you see that sort of happening? And I don't know if there are other states or any other models that we can use as examples of what's of a really good exchange model.
Yeah, I think there are states where that are probably ahead of us in terms of data exchange, and I think the housing folks are ahead of us in their health information exchange. One of the biggest challenges we've had as an office is, well, what are we going to measure and how are we going to measure it and who's going to measure it and um, where will we get the data? And it's those are maybe this sounds naive, but those have been surprisingly difficult to me anyway, having been in the VA for a long time. Conversations, and we are happy to be partnered with county care, so we may be able to get some public health data from within that way, and may be able to get some other um, managed MCO data. But it's striking to know that when you ask a question, how long does it take to get an appointment for a psychiatrist, for example? Um, those aren't data that are really that are
Yeah,
really tracked or easily available. So so I think that it- the health information exchange and Unitas is there are a lot of folks, there are a lot of agencies within Unitas, and there are some um, there are some points of light there, but it is striking how big those challenges are and how far, in a lot of ways, we have to go um, to get meaningful kind of public health dashboards for behavioral health.
absolutely.
Not necessarily the most encouraging answer, but
That's okay. And
that's where we've been.
well, we have a few questions here, and I see three of them, and I'll try to ask them in the next whatever 4 or 5 minutes we have. But The first is, thank you for presenting a picture of what's happening and where you plan to go. Besides funding, what do you see as the biggest barriers to accomplishing your goals, and what could be done to assist you in overcoming those barriers?
This sounds really simplistic, and maybe it is, but folks are really, really busy, and figuring out ways to coordinate efforts rather than having each organization solve its own problems and utilize all of its own resources. That's really been a theme for us, first of all, within the CCH system, but it's also been a theme outside of it. And I think a lot of the barrier is just getting things started, getting people in the rhythm of talking with one another and meeting together and developing plans together. And in order to do that, you, as an agency, obviously have to demonstrate that we're going to make a difference together. But as time goes on, we hope to be able to prove that.
Well, it sounds like the Cook County Health is a convener. It's helping to align a lot of these efforts. So, second question is, can you discuss how you hope to integrate strategies with county care and health services at the Cook County Jail?
Well, we are in the middle of crafting. They're crafting their what I believe is their first. We're calling it a strategic plan. It's probably more like a lengthy action plan. And haven't even fully we're not to a final draft of that yet. So I would say the first piece of that is recruitment, because there's been a lot of vacancies, particularly at CERMAC, fewer at JTDC, but Juvenile Temporary Detention Center. But one of the problems within the CCH system, and I think this is not just in behavioral health, it's really across the board, is a lot of really amazing people doing amazing things separately. And so we've been trying to coordinate the efforts of the CERMAC and JTDC folk with efforts that are happening outside the carceral settings as well. So that's a kind of evasive answer, but I'm hoping to have a plan that we can unveil for that. Actually, in the next few weeks.
Oh, good. Well, look forward to it. And then
And
finally,
we also have to integrate the work that's done by the sheriff's office, which is separate jail from the work of the CCH staff in the jail.
yes.
So everybody's doing good work, but that's not, again, the theme of coordinating that together.
Well, one last question in the last minute or so. Can you talk about how this work is being integrated with efforts of the Chicago Department of Public Health?
We meet with CDPH frequently. Matt Richards of that office just moved over to a position actually at county. So our partner there is no longer it's no longer there. He's actually here. But Jenny Hua, who is taking over that role on an interim basis, and I have met several times. We not only our office, but and CDPH, but also CDPH. Those behavioral health folks meet. So again, as you and I were discussing briefly before the call, it's a very collaborative group of folks. Folks that have gone into public health are a very teamwork oriented bunch, and so they've been absolutely amazing partners.
Well, excellent. Well, I know, Deborah, you probably have some closing remarks. I just want to say one more comment that came in the chat. It's not a question, it's a comment. It's more of a testimonial on how amazing your office has been in the first of all conducting meaningful assessments of the entire behavioral health landscape. And secondly, how your office has garnered input from the field and actually used that input to develop programming and planning. So thank you, and hats off to you for all the work you're doing, Dr. Nutter.
Thank you. Thank you for this opportunity.
I'll turn it over to you, Deborah, for closing remarks.
Thank you so much, Dr. Allen, and thank you, Dr. Nutter, for a very informative presentation. A lot of details, a lot of hard work over a long period of time. So we appreciate that. Just in closing, I wanted to remind you that IOMC is a not-for-profit, an independent not-for-profit. So if we appreciate every donation, large or small, for our programming efforts and also for our initiatives. As we mentioned earlier, Dr. Allen is the chair of the Behavioral Health Work Group for IOMC. So your donations help support his efforts and that team's efforts all together. And also our other dominant work group is Maternal and Child Health, which is chaired by Dr. Anita Stewart, who is a fellow, obviously, of IOMC. So please, please feel free to donate, as you can. Thank you again for attending today's session. We hope that you'll consider being a fellow. I just want to make one mention on looking at becoming a fellow of IOMC. The process involves filling out a simple application, which we're glad to assist you with. Also providing your CV and a list of accomplishments, which probably most everyone on this call has a very, very thick, long CV as a whole. The process does take about 8 to 10 weeks because it goes through a review process with the membership committee, and then you're approved by the Board of Governors as a whole. So keep that in mind. We hope to be able to see you at our spring in-person event that will be coming up and announced soon. And consider nominating someone for the Leadership Awards. So there are many unrecognized or not recognized enough individuals who are doing a lot, and it's a great time in order to honor them. And we hope that you will attend the 2025 Leadership Awards in June. So have a good afternoon and a good week. And thank you both Dr. Allen and Dr. Nutter today for your time and your commitment.